for most primary care providers, this is not going to be a common topic. Staph aureus is incredibly common in children, and it usually causes mild infections, skin infections, eye infections. Sometimes it'll cause something more invasive like a bone infection, but it rarely in children outside of the hospital is life-threatening. Babies in the first few months of life are really a unique population that is especially high at risk, and why we focus so much on this population with regard to staph infections. So I think for pediatricians to be aware of this, pediatricians spend a lot of time providing anticipatory guidance for families. And when their babies are in the NICU, oftentimes they're looking to their pediatrician, who they may have a relationship with because of an older sibling, for advice and guidance. So pediatricians can remind parents that there are risks that to babies while they're in the NICU, and the family may do things to help protect the baby from those risks. For example, we have previously shown in a trial that parents are a reservoir for spreading staph to babies, just like moms can spread group B strep to babies. So I think if pediatricians engage with parents and say, when your patient or your child is in the intensive care unit, you have to think about what risk you may pose to them. There are lots of good things you do for them by being there and being part of their time there for bonding and breastfeeding and skin to skin and support, but there are risks. So there are other things we can recommend, like making sure they're washing their hands, not coming if they have a cold or fever, or wearing a mask to protect the baby. So there are things that pediatricians can help contribute to the safety of children who are in the neonatal intensive care unit by providing that anticipatory guidance for parents. So I do think they can play a role for sure. I think the comment then for the neonatologist, though, is just because they don't see something commonly doesn't mean it isn't impactful for that child. So what I'm hoping we can do is change the conversation to, yes, this is a high risk situation for these preterm infants. And are there more things we can do to protect them? It's not that there isn't a lot going on for preterm babies, from protecting their lungs and their brains. And there are all these other things that make them very vulnerable that impact their long-term outcomes. But my job and my interest is to also focus on those infectious outcomes that we know can be impactful for neurodevelopmental outcomes and long-term outcomes as well. So I really want to help protect kids from infections so that we can make all those other efforts that the neonatologists are doing equally beneficial in the long run. I think the question right now is, it will come up as like, what can we do? I think the importance of epidemiologic studies is to highlight problems, but it's not to do that in the absence of trying to think about solutions. So we do know that there's a growing body of literature showing that if kids are colonized with staph, meaning they acquire staph on their body in a way that is not yet causing infection, there is an opportunity to treat or try to make that carriage or colonization go away. We call that decolonization. And there are a number of studies that have shown that decolonizing babies can make the bacteria go away and may protect them from infection. So I would hope, and it's challenging, but there's enough evidence in children that I think we need to ask ourselves, have an important, I think clinicians need to have an important conversation about the risks and benefits of strategies like decolonization in populations where the risk of disease is this high. Does the benefit of decolonizing a child as a prevention strategy outweigh a potential risk, knowing now that there's a 5% increase in mortality in kids that get these infections? And I think one other thing I didn't mention just is when we talked about a 5% increase, when we compared similar children, the risk of mortality was about 1% in children that didn't have an infection and more than 5% in those that did. So it wasn't just a 5% absolute increase. but it went from about 1% to 5%. That is a huge mortality difference in similar babies that do or don't have infections. So the impact of this is great.